Hello, Happy New Year. Welcome to 2024 and welcome to another year of Let's Talk SADS Live Canada. I'm your host, Dr. Shu Sanitani, and I'm coming to you from Vancouver, British Columbia, and delighted to be back. We had a very exciting first year of this program, and we weren't really sure how it would go, but we found that we had a lot of people tuning in. We had some wonderful guests, and even had some fun along the way. I think many of our audience ended up watching some of these sessions in the evenings after their workday and coming back to us with some questions and feedback. So wherever we are reaching you now, welcome. And this is a place where we come together to learn together about sudden arrhythmia death syndrome conditions, SADS conditions. So those conditions that affect particularly young and cause sudden cardiac arrest or even sudden cardiac death. And many of our audience are living and hopefully thriving with SADS conditions. So our goal is really to learn and explore and make sure we answer your questions. So we've also had some fun, as I say. So last year, each time we would present well, I called it a fun Canadian fact. I don't know how fun they were. They were sort of historical facts. And what we did is we had a trivia contest to see how closely you were paying attention. And of course, you could go back and just watch the trivia part and figure out the answer. And so thanks to Evan Kruger, who organized a fun game, and we are delighted to have a winner. Our winner is Caitlin Gladney Hatcher. So congratulations, Caitlin. And you receive a $200 prize for getting the answers correctly and being drawn out of a hat. And so hopefully you are watching and celebrating. So thanks for playing. This year, it's as usual, we are still dependent on your support, and so I will ask you to see if you can support us in any way. We're exploring an in-person meeting, which of course costs resources to bring people together and rent rooms and that. So, but also just to put on the educational programs we're doing and to have someone keeping the lights on at the Canadian SADS Foundation. Pam Husband has been our tireless leader for the existence of the Canadian SADS Foundation, and so we're very grateful to her. And your support means a lot to us. Whatever amount, you can take a picture of this QR code and donate. I made a donation, and it's very easy to do. So, as I mentioned, a new year. So a couple of things we're going to think about. One is we're going to do not a Canadian fun fact. We're going to give you a SADS Did You Know? And we're going to have a contest at the end of the year as well. And so this year we're going to do a Did You Know? And so you don't have to be a medical person to interpret these, and they're not all going to be complex medical tracings. But what this is showing here is a tracing. It's a heart rhythm of someone that's hooked up to a monitor about 20 years ago. And there's what you can see is that one of these complexes goes down and one goes up and down and up and down and up. And we call this bidirectional. So it's going up and down in an alternating manner. And so the did you know is that bidirectional ventricular tachycardia is caused by digitalis toxicity. So digoxin is a heart medication that has been used all over the world for decades, if not centuries, and comes from a plant. We recently had a child who ate the plant, which is not advisable. But you will see from our topic today why bidirectional ventricular tachycardia and digitoxicity are of interest and relevance to SADS conditions. So that's our did you know that bidirectional VT is caused by digoxin. So new year, so also a bit of rebranding, and we've got to work a little bit on our formatting here, but we have a new flashy slide. And today we're delighted to bring you the secrets of CPVT. And those of you who have been watching, you know that I don't do the best job of introducing our guests. It's often a off the cuff remark without giving them full kudos, which I'm gonna try and do a better job today, because our guest has so many accolades that I'm gonna read some of their recognitions. So our guest today is an expert in genetic heart disease, and from the Netherlands Heart Association was awarded a grant in the early part of his career. In 1999, he became the head of the Laboratory of Experimental Cardiology. And between 2003 and 2020, he served as the head of the Department of Clinical and Experimental Cardiology at the Academic Medical Center. That's a very long tenure to have such a heavy administrative role. I can barely handle half of that in my role. Adding to that, the chair of the Heart Center Division for 7 years. He has been one of the leaders internationally of research and clinical care of SADS conditions, has served on the SADS Scientific Advisory Board, and has written hundreds of manuscripts, and really has developed one of the standards of clinical cardiogenetics facilities. And several of the people that work in Canada have trained under his guidance. In 2011, he was appointed as a member of the Dutch Academy of Science, received the Distinguished Investigator Award of the Heart Rhythm Society in 2012, which is a very high honor. In 2023, the gold medal of the European Society of Cardiology. So I'm delighted today to welcome Dr. Arthur Wilde, and delighted to be able to collaborate with him and have him come and share the secrets of CPVT with us. So let us bring Professor Arthur Wilde into the studio. So welcome.
Thank you. Sure. Good morning to you all.
Yes, thank you, and good evening, and thank you. So Professor Wilde has stayed late. He doesn't have an office like that in his house. So he has stayed late to join us. He's joining us from Amsterdam, and welcome. It truly is a privilege to have you. My introduction was understated, if anything. We're going to talk today about CPVT, although we could talk about any of the SADS conditions. You've been a leader in all of them, but we're going to focus on one of your and my shared interests, catecholaminergic polymorphic ventricular tachycardia. So before we get into that, I want, if you could, just take us back a little bit to your journey. How did you get to be interested in SADS conditions? When did you first start encountering them? Give us a bit of a journey.
Yeah, thank you, Shu, for all these kind words. So I did my PhD in the experimental cardiology department that you mentioned, and that was between 1984 and 88. And that department was part of the famous cardiology department of Professor Durre. Dirk Durre was one of the founders of electrophysiology, and he was in Amsterdam, and he had an experimental cardiology laboratory where I did my PhD. I trained thereafter in clinical cardiology and clinical electrophysiology, and then I started to see patients in the clinic, and many of these patients were initially seen many years before I came by Professor Durre and Professor Wellens, who was one of his pupils in those days. And these patients with rare diseases that nobody understood at that time all came together in Amsterdam because of the famous professors Durre and Wellens. and I saw them and I got interested in them. The topic of my PhD was on ion channels and myocardial ischemia. But because ion channels at the same time that all came together were at the basis of the long QT syndrome, that's where our field started, the genetic underpinning of our field started with the long QT syndrome in 1995. And because that appeared to be based on ion channels, I saw the patients. I knew something about ion channels, so things came together. And from that time on, I became fascinated and intrigued by these conditions.
Fantastic. And those are, for those of you who are maybe not as familiar, I mean, certainly Hein Wellens is, a giant name in electrophysiology. Durer, as Professor Wilde has said, really was one of the founders of the understanding of the field and the flow of cardiac electrical activity through the heart. So to be at such an iconic place.
Let me just stress that was more or less accidental, and this was great luck at the early part of my career, that being raised in such a department. If you are a student, you don't realize how famous these people are, but you realize very soon in your career that they really are, and that is really at the basis of my own career, because the patients were there at the moment I started.
And you have continued that. We have been collaborating for, I think, over 10 years now, and we've seen you continue that with very talented PhD students who then do their clinical work. Christian van der Werf, Christine Lieve, Puck Peltenberg, Auke Bergman, all these names that are continuing the tradition. So it's a real center of excellence. Our own SADS Medical Advisory Board members, Rafik Tadros, Thomas Roston, all have spent time with you. So it's a legacy of mentorship and discovery. So CPVT was not really recognized in those early days. The first, not the first report, but the real seminal report is credited with our friend and colleague Antoine Lienhardt, the 1995 paper. Were you seeing patients around that era?
Yeah, well, not with the recognition of being a CPVT, but shortly after, yes, we did, because there were these patients, and we actually seen a few that were already known from the 70s in Amsterdam. And actually, one of them was accidentally put on flecainide in the early 80s when the drug was just available. And that patient proved to be doing very well, but he was not recognized as a CPVT patient only after, in 2005 or 6, he was recognized as a CPVT patient, but he was already 20 years on flecainide at that point in time. But so I think early in, late part of the last century, we started to recognize. We had one family. We did the genetic studies, and we ended up with linkage to the chromosome 1 area where the ryanodine receptor is located. But we never found something, and that appeared to be a family with, as you know, you have this exon 3 deletion subpart of CPVT, and that family was an exon 3 deletion family, and you don't pick it up with the regular cardiogenetic methods that were used in that time. So we missed that at that time, but we described it in 2007 or 2008. But that family was the first CPVT family that we saw, and over the years, many more came to our attention.
You've touched on a lot of things that I'll want to come back to, including the flecainide story. Now, I still remember attending a talk. It was probably at the Heart Rhythm Society meeting, where you were describing that because the ryanodine receptor gene is so big, at that time we were not even testing all the exons. We were selecting, I think, about 40 exons. Exons, of course, are part of a gene that result in the proteins, but this protein is so massive we couldn't even really get our hand on the whole thing. Of course, technology has advanced, and now one can do the whole gene. But now in Amsterdam, there's this R420 W founder. So I would have thought that family would have come to attention first. Tell us a bit about this founder population.
Yeah, so that family came a little later, but still quite early. It is in our first papers on CPVT, and it turned out to be a very big family. You don't realize at first that it is such a big family because there are different probands. But it struck us that the probands all came from the same small village in the southwest part of the country. And then you, of course, think, could it be that these these different probands are actually family members from each other? And then by going into the family, you quickly find out that they are. And this was actually it turned out to be a very big family with over 100 individuals affected, many children, and all these children were in the same primary school in that small village. And that was one of the only times still that we planned an evening in the primary school to teach the teachers and the parents about this syndrome, because there was a lot of turmoil when this was recognized as a potentially lethal condition. That was really a need for proper education at the level of these teachers. So we went for an evening to a primary school in a small village in the southwest of the country, and learned them about CPVT, and also, and that is, I think, very important for these families, that with proper treatment, there are not that much limitations for these children, so they don't need to be put separate when there is the gymnastic lesson or whatever. They can join it as long as they are on proper treatment, and that is something they need to know and they need to hear from you.
Yes, and let's come back now to that flecainide, because we're gonna talk about proper treatment, and I think you have helped establish that the proper treatment includes flecainide. So for our audience, flecainide was not designed as a CPVT medication. It was designed from other arrhythmia medications intended mostly for adults who are having arrhythmias. And in fact, the famous study of flecainide was really quite damning for the drug, because the people on the medication did worse than the people without the medication, the CAST trial. But that wasn't the end for flecainide, and you and your team really around 2007, 2008 were presenting data on this.
Well, the credit here goes to Björn Knollman in Nashville. He's a basic scientist and a pharmacologist, a basic scientist, and he isolated the ryanodine receptor in a kind of membrane, very small preparation, and with that isolated ryanodine receptor, he studied the function of it, and he applied different drugs, more or less all drugs available at that time, and he found out that flecainide was a potent drug. It was potent in blocking the ryanodine receptor. And then I think in the same meeting as you were discussing, one of these meetings, HRS, I met with Björn. I knew Björn from other moments during our career, and I met with him. He told me this, and I told him I see patients with CPVT who are not that well controlled, so I can easily try flecainide in these patients. And I discussed it with back home. I discussed it with two patients who were really not well controlled. They tried flecainide, and their exercise test was almost clean after flecainide, after a week of flecainide treatment. And that information was, together with the basic data that Björn put together, was put in that Nature Medicine paper in 2008. And that was the first. And then after that, Christian van der Werf, you mentioned him, was a PhD student at that time, sampled together 32 patients from around the world, all not well controlled with the standard therapy at that time, which was a beta blocker essentially. And when they had flecainide added, and the vast majority of them did very well on the combination therapy. So that was the start of flecainide, and that start, when you do it in a normal way, you should actually have a randomized blinded trial. But because that first observational study was so successful, the attempt of the clinic in Nashville, the Vanderbilt clinic by Prince Canaan, who wanted to test this in a well-designed clinical trial, but he got problems with including patients because there were already so many CPVT patients on flecainide, because it had already been shown that it was doing well. And the cardiologists or pediatric cardiologists involved put their patients on flecainide before that randomized trial was ever done. Now that seems a bit odd, but we have to realize that the very same thing happened with the long QT syndrome 30 years earlier when our older colleagues started beta blocker. There was never a randomized trial for beta blocker in long QT syndrome, but everybody realizes that the long QT syndrome is very well treated with beta blocker, so there will never be a randomized trial. And the same will happen with flecainide, I think. There will never be a randomized trial. We are convinced that it works. We just published a longer follow-up study in over 150 patients, and the effects are very similar to that initial study in 2011.
Yes, congratulations on that paper. That was in circulation recently, and we were proud to be part of that. And also, yes, a big shout out to Prince Canaan and Bjorn Nolman. The Prince's trial, the flecainide trial, was very challenging. I think the patients also had to have defibrillators, which was another sort of inclusion criteria, if I recall. But so here we are, and really, I will take this moment to say that in general, we strongly recommend beta blockers and flecainide for those patients who need it. So for those who have symptoms or breakthrough episodes, or whose exercise test warrants it. And so, of course, talk to your specialist. But certainly, we would prefer to see a higher uptake of flecainide as opposed to defibrillators. So let's for a moment change direction. And you're also part of a very important piece of information. So a patient can present with a cardiac arrest. So the first sign that they have CPVT is a cardiac arrest, and they get rescued, CPR or defibrillator. They get rescued, or they have a self-limited episode. You and your group published a very important paper that defibrillators did not improve the survival of this group. So tell us a bit about that, because I know for many of our audience and health professionals as well, it's very difficult to not put a defibrillator in someone who has had a cardiac arrest.
Yeah. So before addressing that topic, let me make one more comment on flecainide. I think one of the reasons of the still limited uptake is that CAST trial that you mentioned. Doctors still think about flecainide as a dangerous drug, but you have to realize that the CAST trial was in patients with myocardial infarction and overt myocardial ischemia, and that's a completely different subset than the young CPVT patient without myocardial ischemia or anything related. And the sub-studies of the CAST trial clearly show that the pro-arrhythmic effect that you described was indeed related to the fact that these patients also had myocardial ischemia. So I don't think there is any reason to believe that flecainide is a dangerous drug in CPVT patients. The only exception is the CPVT patient that gets older and might develop ischemic heart disease over time. And in those patients, we are very careful, as I see many adults with CPVT. In those patients, we are very accurate with every time we see them, asking them about chest pain, angina. And whenever there is a single symptom, we have to stop the flecainide, and we will stop the flecainide only then. So the question on the ICD, to the patient that has as a first symptom a cardiac arrest, CPVT patient with first symptom cardiac arrest, almost always is not aware that CPVT was diagnosed. So that particular person is also not on any treatment. Now, being not on any treatment means that there is no protection whatsoever, and we are convinced by experience over many years that in general, a patient with CPVT, and that is the regular patient with CPVT, is very well protected with the combination of beta blocker and flecainide. We use the exercise test as the readout, and as long as the exercise test is free of arrhythmias, a single exosystole is accepted, but anything more than single ectopy is unacceptable. But when the exercise test is like that, I think the patient is free of risk. There is some literature, also from Paris. You mentioned the group in Paris, which also have been very important in this field. And they have one of the studies in around 2010 also clearly show that the patients that are on continuous risk are those patients who are not well controlled during exercise. So when your exercise test is well controlled, and that is defined as not more than single ectopy on the test, then the patient is well protected with beta blocker and flecainide.
In your healthcare system, are you able to wait until the patient can do an exercise test before someone will say, "Oh, I have an opening in the schedule. We must put the defibrillator in and get moving"?
That is if there is a suspicion on CPVT, we are not implanting the ICD before we have done an exercise test. And if the exercise test, so genetic testing takes long here, actually much longer than in the US or Canada. So we cannot wait for the genetic test, but we can definitely wait for an exercise test. And we make room for the exercise test before implanting an ICD, for sure. And then if the suspicion is on CPVT, we can ask for rapid genetic testing. That abbreviates time significantly, but it still takes a few weeks. And we start with treatment, and if the treatment is successful, we leave it at that point with that. If it's not completely controlled, so still remaining arrhythmias, we consider a surgical procedure, which is the interruption of the left stellate ganglion, which is the adrenergic system innervation of the heart that has the left side and the right side, and the left side is the most important. And you can interrupt these branches of the adrenergic system by a small surgical procedure that is with the video camera nowadays. It seems very easy. I'm not a surgeon, but I've been present in the OR many times, and it looks as a very easy procedure. You interrupt these branches, and then you repeat the exercise test, and actually you can do the new exercise test only a few days after the surgical procedure. And then you will see that almost always patients are free from arrhythmias. And in our view, that is sufficient protection also for a patient who started with a resuscitated cardiac arrest. And the other thing that needs to be addressed is that the defibrillator is not without problems either. We just spoke about the necessity of a randomized trial if you enter a new drug. Well, we don't have that randomized trial for flecainide, but we also don't have a randomized trial for the efficacy of a defibrillator in CPVT patients. And that is an issue because there is a potential pro-arrhythmic effect of a defibrillator in a CPVT patient. Anyone who has a defibrillator and who once has experienced an inappropriate shock, he or she will know that is a very painful experience, raising adrenaline in your body immediately, and that in itself, in this particular condition, might lead to the next arrhythmia. And that means that if there is an inappropriate shock because of a broken lead or because of an arrhythmia that doesn't need to be shocked, that inappropriate shock can lead to a sequence of events of true arrhythmias, true ventricular arrhythmias. And if there are a few in a row, and usually defibrillators have the opportunity to shock 6 times in a short period of time, and after that the defibrillator stops shocking, so that potentially can lead to death of the patient. And that all started with an inappropriate shock. So that, and there are several case reports from Canada. The first one were actually from Canada, where patients with CPVT died despite their defibrillator, and the conclusion of these papers was that they died because of the defibrillator. So we think that is another reason to be very careful with the defibrillator in CPVT patients. But at the same time, we have to realize that if there is a need for a defibrillator, you should not hesitate to implant a defibrillator, because it's not an absolute no-go. It's a relative no-go.
Yeah, no, absolutely. And, so I just to restate some of that. So I think all of us agree beta blockers, a low threshold for flecainide, and then cardiac denervation. And with those 3 layers, and probably done, stepwise, ideally, but with those 3 layers, very, very few patients need anything else. And that really is, as we were talking about earlier, really optimized medical treatment. There will be rare patients that, despite that, need additional therapy, but those are very few. Now, the comment about, you had mentioned gymnastics in the elementary school. What are your general recommendations about activity? So let's presume that we have this patient who is well managed, and we know that some beta blockers are more effective than others. I'll take a moment there was a concern about Nadolol being not available in Canada and Europe. This is, I think, just one formulation of it. So there's still Nadolol available. So don't panic and continue to take what you have been prescribed. So what are your activity guidelines or the conversations that you have?
So all the patients have an exercise test and have a regular exercise test. And if that exercise test is without ectopy, I used to tell them that this is what they can do. And they can translate that to whatever sport they do. And the only sports that I really do not advise is high competitive sport, because that is difficult to test. If we do an exercise test in our regular clinics, that will not be similar to a highly competitive effort in an athletic stadium or whatever. And the other sports that is something that we do not promote is swimming, and then race swimming in particular, because swimming in itself, the diving in itself, is known to be a specific trigger for CPVT. So that actually are the only exceptions. But if a patient is well controlled, I have no problem with anything with any sport, as long as it's not at the very high competitive level.
Yeah, and I'm not.
Sorry. The one addition. The example that I always give is that, and that is a problem we have with our exercise testing in the clinic. I had a patient, a soccer player, young man, and he once told me that if there is a ball in the field and the ball is running out, he runs after it. He wants to keep the ball in the game. Nothing happens. But if somebody else runs with him, then the there comes this competitive element in it, and there is both the physical exercise and the competitive element, then he feels the arrhythmia and he might actually even have an event. So it is that competitive element that changes things, and that is not easy to test in our settings.
Yeah, and I think you and I have both seen cases where the nature of the adrenaline is the mysterious factor.
Mm.
You know, that someone will do something, you know, routinely, you know, hundreds of times, but on a certain day it's different. And you know, is it that there's someone running next to him for that same ball?
Mm.
Is it the nerves? What is that mysterious factor?
Now,
Now,
another example, if you allow me, the first patient who was on flecainide, one of these two first patients was a calsequestrian patient. So that is a rare form of CPVT, more deleterious than the regular CPVT. He's done very well on flecainide for 7-8 years, and the first breakthrough event was in the semi-final of Holland Got Talent. He was a rapper, and a rapper with a lot of physical activity, and he was in the semi-final of Holland Got Talent. I assume that's a television program that is, I know it's in the US, I'm not sure it's in Canada, but that was broadcasted on television, and that is the time that everything came together. So he was nervous, he was rapping, everything came together, and then he had a breakthrough event on flecainide. He had an ICD, so he was shocked. But that shows you that indeed, if the adrenergic trigger is strong enough, it breaks through everything.
yes, and I don't actually know if we have the Canadians Have Talent show, but certainly that is a clear example of where adrenaline is different when you're being in that kind of competition. Now, in our remaining few minutes, and you know, your group, as I mentioned, you have really led the field with these family clinics. We were talking about, you know, multi-generation families. Actually, before that question, let me ask you, particularly in the founder family. So founder is, of course, you know, a condition that keeps existing in a population because the genetic risk gets passed from parent to child, and so on and so on, and it grows, it expands. The condition isn't necessarily the same in everyone. So does everyone who has a genetic risk for CPVT, does everyone get a beta blocker in your program?
No, so the founder family has the particular characteristic, which is also different from other CPVT patients, that the onset of events, of symptoms, is relatively late. So it's not in the very young, as you see many patients. It is after puberty, I would say. I don't think it's related to puberty, but it's just at a certain age that it starts. And in that particular founder, it is relatively late. So these individuals are guided by exercise tests early on, and as long as the exercise test doesn't show any ectopy, they are not on therapy. But as soon as you see the first extrasystomy, they are put on therapy and further scaled up depending on what the exercise test shows. And not everybody develops a phenotype, so some patients never are. They're always on exercise tests, but they never show ectopy, so they will not be on therapy at all. And that is guided by the exercise test. Now, the intriguing issue, of course, is why some patients do develop arrhythmias and other patients with the very same genetic conditions do not. That I don't think is explained in CPVT. In other SADS conditions like long QT, we know that other genetic defects contribute to the phenotype, to the severity of the phenotype, or it can also be opposite. It can be a beneficial variant that protects you from suffering from the phenotype. So it is probably based on the genetic profile of this individual patient, whether there will be a phenotype, whether the phenotype will be severe or less severe. But for CPVT, that's a complete unexplored area. But my bet is that in the near future, we will learn, and these these founder families are actually the ideal group of patients to learn from, because there you have 100 patients with the very same genetic condition. So that cannot be different between the different, and then the other factors cause the difference between the phenotype. In general, all the CPVT patients, many of the CPVT patients have a different variant, a different mutation. And both of us work closely together with Dr. Chen in Calgary, and he's the expert on the biophysical aspects of the ryanodine receptor, and he has clearly shown that every variant has causes a different grade of dysfunction of the ryanodine receptor, and the more dysfunction there is, the more severe the phenotype will be, and the less dysfunction, the less phenotype there will be. So it starts with a particular variant that causes a particular dysfunction of the ryanodine receptor responsible for the phenotype in general, but then the variation in phenotype is probably caused by many other genetic factors. And that can be several, and it will not be easy to find them all.
Yeah, the ryanodine receptor itself interacts with so many proteins and is such a complex molecule. So we're still back to your PhD in some regards, the science of ion channels. So in our remaining few minutes, I just want to take advantage of your wonderful contributions and your incredible insights, and maybe just if you could share just one or two of your main learnings just in general of the SADS conditions. I know your clinic wrote about some of the learnings after your 15 years of a inherited arrhythmia program, but just maybe just for me and other people who are just so in awe of your contributions and your understanding, what are some of your insights?
Well, I think one of the things I was very pleased with over the many years I've been in this practice is the fact that we started with family clinics where the parents and the children, and sometimes even the grandparents, all come at the same time. And the big advantage of that is that they hear the same story. So if other doctors are involved in the care for children and for adults, then the adults get many times a different story than the children or the grandparents. So trying to do that all together in one room, together with the pediatric cardiologist, is I think a big advantage for everyone, also for the doctors, but certainly for the families. And the other learning point is that I've always been in the privileged position to be close to an experimental group. That is, my basic training was in that, and that helps in understanding these conditions, if you know something about basic electrophysiology. And we have multidisciplinary team meetings, which are very important. We have a genetic laboratory nearby. We do our own genetics. So these multidisciplinary team meetings, weekly meetings with geneticists, molecular geneticists. Unfortunately, we need a pathologist now and then, but these multidisciplinary team meetings are very educational, and they are helpful for everyone involved. And if you're working on your own in a wherever, that is not very helpful for these conditions. I think it's mandatory to work in a multidisciplinary team. So that would be my advice to anyone involved in this field. Make sure you are well connected to geneticists and to colleagues who are in the same field.
Yeah, and I think on that note, it's fitting that we acknowledge also that Professor Wilde initiated the International CPVT Registry, with which we collaborate closely with a pediatric component, and has now thousands of families, or maybe not thousands, but over 1,000 families that are impacted by CPVT, and is really advancing the field and allowing us to learn. And it is really a community in which Professor Wilde has been a leader and continues to be a leader. So thank you so much for joining and for staying in the office beyond late tonight for our audience. I've really enjoyed our conversation. I always learn so much when we do get the chance to sit down, and I look forward to ongoing collaboration and learning. Thank you.
With great pleasure, Shiv. Thank you very much.
Wow, I could just sit and ask him questions. And that's just one of the SADS conditions. He's as knowledgeable about all of them. Really, one of the giants in the field, and really advancing the science. So that's our show for today. We are excited. February is Heart Month, so we're going to mix it up a little bit, and we're going to turn over the microphone to our audience, and we're going to have a Q&A format where no holds barred. We're not here to review necessarily your personal journey through the healthcare system or your frustration at getting a family doctor in Canada, but we want to take your hard SADS questions, and we'll do our best to advance our knowledge together. And so thank you so much for joining. I'm excited about a year of learning together. And don't forget our Did You Know? Fun fact. We didn't actually explain that, but bidirectional ventricular tachycardia is one of the classic rhythm abnormalities in CPVT, which is why we showed that digoxin slide. So there was some method to my madness. So that's it for me today. Thank you so much, and I hope you enjoy this wherever you're viewing.